And I also wanted to talk, a little bit. These are some of the practical approaches, and I think that understanding some of like the barriers and the sorry, I had COVID 2 weeks ago. It's not COVID. The barriers and the solutions to kind of help your clinical practice and your institution. A lot of my knowledge is based on these qualitative interviews I've been conducting, and I think one of the key things is just that it's a very foreign environment. Most people have some sort of situational awareness when they kind of go out, know their home, know the common streets, but the hospital is often a very foreign place, and so they often do go back to the hospitals they're familiar with just because they have more awareness of the layout. So from the minute they step out of their car, they have or the taxi or whatever they've taken, they don't know where they're going. And so, a lot of times they kept asking, some of the stories that kept coming up were like, we wish you had volunteers or somebody who would just guide me, provide sighted guide to get through the institution, to get to the ER. And then once you're in the ER, they're basically sitting in a stretcher and they have no way of really communicating with staff or to ask for assistance. Hopefully the call light rings. Hopefully somebody will answer the call light, but they can't even see if somebody is like there or not. And so they can't flag somebody down. They can't say, I need to go to the bathroom and get that assistance to get there. So just this complete being in a foreign space is very hard, and I think some of the solutions are basically having like the nurses that kind of make it part of their practice and educating them to check in on the patient, see if they need comfort need items, seeing if they need to go to the bathroom, having volunteers to kind of help provide sighted guide or kind of instruct them in the hospital on where to go. Some of our interviewees were saying that Mass Eye and Ear does a great job of it just because all their staff has been trained in sighted guide, and so they actually do a phenomenal job because they're more of the patient population has these needs. And some of the other kind of environmental those are the environmental barriers and the communication barriers. Some of the organizational barriers is that many people don't even know they are blind, and so they don't, like when they walk into a room, they don't know to like kind of change their behavior and make sure they are speaking. And so having signage or some sort of indication for providers and other staff to know that, oh, I do need to kind of not just assume that they can see me. And like, when you start speaking, you'll see like they're like trying to like place your voice because they don't know that, you have to acknowledge yourself. One good thing is to put them in like a private room or have like a door so people can knock on the door, and that's always a good habit to get into is when you knock on a door when you walk in. Because, you're laying in bed and then all of a sudden you hear a voice. And so it's often startling. And then, like, saying what you're doing. And so saying, I'm going to touch your left arm, I'm going to touch your right arm, I'm going to listen to your lungs. So you're not, like, assaulting them, essentially, by touching, touching them unwarranted without telling them about it. And then from, like, an institutional perspective, I think, some of the other kind of strategies are having larger signage. Being visually impaired or blind, there's a big spectrum. Some people have no sight, some people can see shadows. And some people are just legally blind, but that means they can still see quite a few things. And so having signage that kind of indicates like in bigger letters as opposed to small like weird symbols that are super tiny to indicate like where the trash can is, for example, or where numbers, like just like bigger high contrast signs are helpful. Having like black and white as opposed to kind of dark colors. And then one of the things that we're currently working on is, like text-to-speech software is very commonly used, and it's so easy for them to even like navigate through like their My Health and apps and stuff to kind of hear about the patient chart because they can like read their entire clinical chart that way. But the discharge instructions from the ER are often not in the system, and so they can't access the instructions they're supposed to follow, and they're given these papers that they can't read. And so we are working to figure out how to like get them emailed to them so they can at least just read their own discharge instructions, and it's not a huge lift. And so our EPIC people are currently working on that, and so trying to get your institution to make their discharge instructions available to them, because that's actually where their guidance is. If you think about most primary care clinics, they say like, hypertension, start amlodipine, blah, 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 and they like actually write down their plan. But in our thing, it's like discharge, instructions and return precautions provided is like what you say as your plan. But that's not actually helpful to these patients who are reading the chart and that doesn't tell them anything, especially if the discharge instructions get lost or get thrown away or whatever, they can't read them. And so I think that's like, there's like subtle, small things that will make a huge difference in the care of your patients. And then I think, obviously education, Jason talked about this, but educating your staff on sighted guide, kind of how to provide this kind of assistance, just making them more aware, not using colors, kind of not just pointing randomly saying that third door over there. You know, you need to provide a little bit more guidance, and being aware that you have to kind of check in on these patients because they don't have we have terrible communication in the ED, so it's hard for them to communicate with us. And so I think those are just some of like the bigger kind of things that have come up and are easy, low-hanging fruit to fix in your hospital. Anything else? Awesome. And then I'm going to pass it off to Corey and Rich for the next group.